Well, thank you and good morning, and I must say I'm impressed. I would not see an attendance like this in Oklahoma at 7:30 in the morning any day. I was just speaking with Dr. Hawthorne, who said knock 'em dead. I said, well, 7:30 in the morning, I don't know how, I might do that myself since I'm coming around. And by the way, I did not mean to get in the way of anybody that's wanting to get food out there. So please, let's keep this very informal. I don't have to get through every slide I have here, okay? So I think it's more important that we initiate whatever discussion you're ready to initiate. I'm here to answer questions. I've been doing this for about 20 years now. Essentially, I went right from just to give you a little background, I'm a graduate of NSU. I went to optometry school there in the mid-'80s. I went right to medical school after that. We were talking about Les Walls, a little while ago. A lot of you know Les. He was pretty much my mentor, and I really credit him as being the guy that got me interested in medicine and got me into medical school. I went and did a residency. I went to medical school at OSU in Tulsa. I did a residency right there in a big urban hospital in Tulsa, and then went right back to NSU. So my entire career has been in optometric education. Based in Tahlequah. We have our main clinic in Tahlequah. We have about 10 clinics then scattered throughout northeast Oklahoma. So we have a very unique model of patient care. We have to, not only be the primary care provider for the patient, but we have to be the patient advocate in all senses, or in all sense of that word. We have to take care of not only their eye care, but we have to be able to discuss general health issues as well, and then get them on the right track, to treatment or preventive health, if that be the case. So our students are brought up as, full scope primary care providers. We need to be able to provide most of the care for most of the folks most of the time, okay? And that is, a philosophy that we live day in and day out at NSU. So what I've got today is essentially a series of clips that I pulled from our teaching clinics, okay? Lasers and office surgery are what we want to discuss, so that's what we're going to talk about. Again, I want to keep this very informal, so if you have a question, please raise your hand, and we will address your questions as we go. Again, I don't have to make it to the end of my slideshow here. Just a disclosure, I actually have no financial interest in any of the devices, any of the lasers, et cetera, et cetera, et cetera. Anything that you might see here, I will be happy to tell you what I like to use, but I don't have any vested interest in any of these products. Again, a little history. I think this helps a little bit to gain a little perspective on where we are. The title, the title of this talk, the future is now. I was thinking about this a while back. The future really started in Oklahoma anyway, in the late 80s. So, all this stuff that we're constantly being asked to speak about, at NSU we have a very active CE program that we take on the road, and we're always talking about surgery. We're always talking about lasers, office anesthesia, other medical issues. And, we are approached, now give us some perspective on what the next 5-10 years may be like. Well, for us, this is the way it's been for over 30 years now. And the other day I was thinking, has it really been 30 years? It was the late 80s when the first lasers were done in Oklahoma. And office surgery actually started not much later than, I would say, the early 90s. While I was in residency, occasionally I would go back for a talk or actually to attend the program myself. And, we were doing a lot of the things you're going to see here this morning. We were doing them in the mid-90s. So, the laser experience is almost 30 years old now, okay? And the surgical experience, if we're talking about non-laser surgical procedures, again, we're into the second decade. So, what is the future? Well, the future has been going on in some places since the late 80s. And I think what that means to the rest of the nation is that optometry has a track record now. This isn't anything new. When you approach, your lawmakers and say, you think that it's important, to be able to provide these services for our patients. And they look at you and say, well, this is all new stuff to me. And, maybe it is, but for the profession, this is nothing new. This has been going on now for almost 30 years, and we have a track record, and I think that, and again, we go from state to state to state, that you should utilize that to your advantage, because we have an established track record now that is decades old. And our outcomes, if you look at outcomes in Oklahoma, and I can speak for Oklahoma, that's where I'm from, versus the rest of the nation, and you look at outcomes comparing optometric providers with medical providers, there's really no difference in outcomes, okay? And how do you measure that? Well, it's kind of hard in a sense. You don't have actual numbers. We have HIPAA and things of that sort that prevent us from getting real specific, but you can look at indirect measures. And there are some metrics, that we rely on. One of is malpractice rates. Okay, you look at the malpractice rates or insurance rates for ODs in Oklahoma, they have not gone up. We have, again, this 20, 30-year experience at advanced procedures, lasers, and surgery, and you look at the malpractice rates, and all that time, they have not gone up appreciably, okay? If there was a problem in providing these services, I would, wager that the insurance company would be on top of that, and premiums would have been adjusted accordingly, okay? And yet they haven't. An OD practicing in Oklahoma, entering practice in Oklahoma, is paying about 1/10 of what I pay as a surgeon, okay? And knock on wood, I have not had any hits against me, yet. But they're paying about 1/10 of what I pay, okay? And those premiums have really not increased appreciably. So that may give you a little indication of just the state of things in Oklahoma and where we are really in other states. It's not just Oklahoma anymore. Kentucky, New Mexico, Louisiana, as of late, Tennessee, other surgical states. Where optometrists are enjoying the ability to provide these services to their patients. Their patients are benefiting, from being able to get most of the health care in one spot, and not being farmed around for things that can easily be done in the primary care provider's office. All right, so we started this in '88. I would say that I remember in '97, there was a challenge. This is just a little the backstory. There was a challenge. I was actually in my ophthalmology residency, I recall. There was a challenge by organized ophthalmology with regards to lasers because it wasn't clear in the law, whether or not ODs or whether or not the state board could actually grant or interpret the statutes in such a way that would give optometrists the license to perform laser surgical procedures. So there was a small challenge there, but they took care of that, very effectively, and then that actually became part of the law, the written law. In 2004, I recall, I got a phone call one night. It was the dean of our college who said, "You're going to be a lot busier for the next few months." And I said, "Why is that?" He goes, "Well, because somebody asked the Attorney General in Oklahoma whether or not optometrists could perform non-laser surgical procedures." Okay, the skin tags, the chalasia, epilation, there are a lot of things that we do routinely which are surgical, I guess, by virtue of the fact that they have a surgical CPT code. Flicking off a foreign body, okay, considered a surgery. So there was a challenge that was, or actually, again, a question posed to the Attorney General: can optometrists in Oklahoma perform these procedures? Now, the Attorney General, a true politician, said, "Well, it's not for me to decide that," okay? So he really gave a vague answer. He said, according to the way the law is written, I would say it doesn't specifically permit that, but again, in my office, it's not I can't be the guy, I can't be the individual that interprets that. I will have to go either to the courts or back to the lawmakers. Well, optometry then took that back to the legislature, and it wasn't but 3 or 4 months before it was now written in the law that the scope of practice in Oklahoma included non-laser surgical procedures. I'll talk about what that says here in just a second. That was, I would say, about 2004, actually. It wasn't long thereafter then that New Mexico got their law. Okay, now they don't have lasers, but they have a minor surgery, office surgery law. And they were able to, again, New Mexico is a rural state like Oklahoma, so they're able to take advantage of that, and I think the communities in New Mexico have certainly benefited from that to a great extent. Kentucky, we probably went to Kentucky for about 5 or 6 years before they got their law. In fact, we still go to Kentucky. I'm going there in July. We put on a course every summer. It seems like most of these states that have moved into what I'm calling advanced practice optometry, not because other facets of optometry aren't advanced, but that's just what I call the addition of lasers and office surgery and anesthesia to the scope of practice. Most of these states will begin by educating the members, okay? And so we at NSU have been part of this for quite a while now. I recall going, like I said, to Kentucky for about 5 or 6 years before they actually implemented their law. New Mexico, we were out there numerous times as well before they implemented their law. Tennessee actually passed a law in 2014, again allowing for a limited number of minor surgical or office-based procedures. And then, as you all know, Louisiana, that is Louisiana State Board member there in the middle, passed their law in 2014, and we were privileged to be a part of that as well. So it's not just Oklahoma anymore. You've got a handful of states, and I will tell you, I've been north, south, east, and west. There are other states where, I guess by virtue of the fact that the laws don't prohibit certain procedures, ODs are taking, advantage of the educational opportunities that are offered nationwide and training opportunities. And they're providing a high level of service to the patients in their community, okay? And again, the communities are the ones that benefit because there's a reduction in cost of care, and there's also an increase in the availability of care in some of these places where, you will never find an ophthalmologist in Slick, Oklahoma, okay? I mean, ophthalmology is an equipment-intensive sport. The hospital there's no way the little, facility they call a hospital there could possibly afford to equip an ophthalmologist or even a room with the equipment needed to do the type of things that we do in a hospital. But optometry is ideally, suited to provide things that used to be hospital-based, because of technology, are now easily performed in the office, okay? And if we can do perform these services in the office, provide these services in the office, that's primary care, okay? And if it's primary care, it's part of optometry, okay? So optometry becomes a more robust profession, and again, it's the communities and the people that live in those communities that benefit. Here is our route. Well, actually, this is one of our surgical areas. We have a couple of places at NSU where we have set up, and some of these are retrofitted. NSU actually is housed in an old hospital. So we have over the years retrofitted and made use of a lot of the space that we had. This is the law, actually, and I know about Oklahoma law. In Oklahoma, we have anterior segment lasers. If you're an OD, you can perform essentially any anterior segment laser procedure. There is no, by the way, restriction on technology. So as lasers evolve, as other non-laser modalities evolve, radio frequency surgery, for example, which I'll talk about in a little bit, there is no restriction on technology. Okay, so as a licensed OD in Oklahoma, you have science and technology on your side, to provide better care for your patients. As far as the non-laser surgical procedures, and the law is pretty specific on this. It's limited to lacrimal probing and essentially dermatology procedures. Okay, so the lesions that we find in the periorbital region are all within the scope of practice of optometry. So long as it's to provide, not for cosmesis, solely for cosmesis, although to provide for the relief of ocular abnormalities, that's really the crux of the law right there. Whatever you do has to be not for cosmesis, but to provide for the relief of ocular abnormalities. That then is within the scope of practice of optometry. And again, there's no restriction on technology. So whether that's the old-fashioned scalpel, lasers, radiosurgical devices, or something that might pop up in the future, that is, again, all within the scope of practice of an OD in our state, anyway. And if you look at New Mexico, if you look at Kentucky, Louisiana, those states have essentially patterned their laws after the Oklahoma law, okay? So that's, it's good because I think there has to be, as this continues to, evolve, there's got to be some standardization, and, I think it's good that, at least in our part of the country, everyone seems to have gotten together and tried to bring some uniformity to all this. Okay, and that's important early on while this is still evolving. There is one of our surgical areas, and it's pretty well outfitted. I mean, there's not much that we cannot do there. Now, we don't do anything that involves an anesthesiologist. We don't do anything that involves intraocular procedures there. Okay, I don't do cataract surgery here. I do a lot of oculoplastics. I'm very comfortable at our facility, and this is something that you could set up in any office. I mean, you don't need this elaborate space here, but certainly the things that are needed to provide the kind of services we're talking about mesh very well, in an office. You don't have to have, specially built facility to do any of this. Just to give you a little perspective, we run these clinics now, and these are our specialty care clinics, that's what we call it. We run these essentially every day. There may be an afternoon or a morning where we're doing paperwork, but they're essentially running every day now. We usually will have an attending OD faculty along with a couple of residents and then a couple of students, our students or externs. We actually get students from other schools now that come so that they can, get a little training in procedures that perhaps are not being offered in their state yet. Okay, I'm there, again, I've been there since the end of my residency, so I'm sort of the consulting surgeon. I have the greatest job in the world because as time goes on, I do less and less and less. And people are doing more and more and more, and I think it's wonderful to see this evolve the way it has. All right, so I'm going to invite you to the NSU clinic here, and it's 8 o'clock. We have our first patient. This is someone that was a cataract patient 6 months ago. We performed a cataract surgery, and 6 months down the road, looks like her vision is dropping to about 20/40. In our exam, the student or the resident sees that, well, she's got capsular clouding. Both posterior and anterior, and one of the things that our students are always gung-ho, ready to do is their first capsulotomy. They are ready to tear, to treat that posterior capsule, and yet they seem to neglect. Everyone seems to forget about the anterior capsule. The anterior capsule, to me, is just as important as the posterior capsule. So watch this. The laser parameters, by the way, are there on the left. I'm not going to spend a whole lot. That was an anterior capsulotomy, okay? If you neglect a fibrotic anterior capsule, you're going to get constriction, and that can do a couple of things. It can shift the lens, okay? With some of these premium lenses that we have nowadays, that's important. It can also put stress on the zonules, okay? So if you have a fibrotic anterior capsule, some of these lasers now have an anterior offset, which make it pretty safe to treat the anterior capsule as well. Generally, what you're seeing here is a posterior capsulotomy. I think this was I remember this one actually. This was a fourth-year student. This may have been their second or third one. You can tell when it's a student because they don't want to, they're having so much fun, they want to just keep going and going. I would say that how large do you need to make that opening? That's always a question that they ask. It needs to be a little bit larger than the pupil. So, you need to have some sense of pupil size. And also, it needs to be centered along, the visual axis. And some people, don't have pupils that correspond to the center of the cornea perfectly. So get a sense of what the normal pupil is in location. Some people have a little, displaced center of the pupil. And so center your capsulotomy to correspond to the optics of that patient's eye. I generally, if, for example, the average person has a pupil size of about 3 or so, or 4, I'll try to make my opening at the time I do my laser about that large, centered, on the pupillary axis. Recognizing that after you've cut these flaps, and over the next week, those flaps are going to contract some, so that space is going to widen, by a millimeter or so. So, you ultimately want the opening to be larger than the pupil so that you don't get any problems with glare, especially if you have a very fibrotic capsule. But you don't want to make it so large that you compromise the stability of the lens, okay? And while it's a lot of fun to shoot, remember that we are adding energy. It is a controlled trauma that we are, administering, that we are overseeing. So we don't want to use any more energy than we have to. Okay, so that's something that we try to instill in our students early on. That it is it's a very elegant and efficient procedure. But again, you're manipulating tissue, and there might be some risk. So we want to minimize those and make this as safe an experience for the patient as we can. So just a little bit larger than the pupil size. We generally will send them home after we administer a drop of something like bromonidine or iopidine. We actually do that before and after. That's to mitigate against a pressure spike. We have a laser course where we go over all this, but I'll tell you the worst thing that can happen with a laser procedure like this, and it's fortunately very, very rare, is a pressure spike of over 10, okay? Because sometimes that is not going to be as amenable to medical therapy as, say, a pressure spike of maybe 5. So what we do is we will administer with any laser procedure, and I'll show you a couple of other procedures here, and you'll kind of read on the side there that we do more or less the exact same thing. We pre-treat with either alpha-GAN or iopidine, okay? And then we will also give them a drop before they leave. And we always check their pressure about 30 minutes to an hour after the procedure. If something's going to happen, it's usually going to be within that time span. All right, so that was a posterior capsulotomy. That's one of the blue chip procedures that all of our students and residents want to do before they graduate or before they leave the program. Yes, sir.
How difficult is it to make sure you're hitting the capsule? I have seen 2 patients where they hit the back of the lens.
They hit the lens. Ding, yes. We call that a ding. And that's not a little bell, giving you a prize when that happens. These lasers have an offset, okay, which means that the actual focus of the laser is pushed back a little further from the optical focus of the aiming beams. Okay, so whenever you are new to this, or even when you're not so new to this, it's a good idea to engage that offset. That pushes the laser focus back, so that when you bring the Heine beams, the laser focusing beams, onto the posterior capsule, and you're focused right on the capsule optically, the laser burst actually occurs a little bit behind that. So that gives you a little cushion so that you don't tend to ding the lens, okay? Now, that being said, occasionally the patient moves or just, for whatever reason you may hit the lens. It's usually not a tragedy, okay? Most of our students are taught to start in the periphery and then work their way down, in sort of a cross-like fashion. So that, you make sure that, you're comfortable, that your patient's comfortable. Sometimes the patients will get a little startled when you start, firing the laser. So you take care of those first couple of shots out in the periphery, make sure everything's working well before you actually cross through the essential zone, the high rent district in the center, of the pupil. But I would say that using the offset is going to help you not hit the lens, okay? And again, some lasers have an anterior offset to where if you're doing an anterior capsulotomy, the laser burst now occurs in front of the optical focus. So you think you're focused right on the capsule, and indeed you are optically, but the laser is actually focused either a little bit in front of or a little bit behind in the case of a posterior capsulotomy, so that you've got a little bit of a safety zone there, which might, or in theory, will prevent damage to the optic or the lens. Okay, did that answer your question, sir? Okay, so our next patient then is a new, someone, let's see, well, not a new, glaucoma patient for about 6 years, but as some of these patients are very non-compliant, we tend to see a lot of these. He actually had ALT. Okay, we don't do very many ALTs anymore since we purchased an SLT. But this individual apparently had an ALT performed some months ago and did well. Okay, treated 180 and got a pressure drop of 3. That's not bad for an ALT. So he's back, and they're going to do the other half this time. So here's an ALT. Now ALT, it probably wouldn't be the first laser I would want to teach you. What are the skills you need to do this well? Well, you have to be very good at gonioscopy, okay, number one. You also have to have some sense of, some spatial sense, because, with ALT, you're trying to place those burns about 1.5 or so burn widths apart. So, you're kind of gauging that mentally as you go. ALT also is very dependent on, or more dependent on position than SLT is in this day and age. So, you have to actually identify your landmarks, and the placement of those burns, relatively speaking, compared to SLT, have to be fairly precise, or you may not get an efficient or as good an outcome as you would. And there may be some complications. If you're too far back, for example, you may cause a little more inflammation. You can cause some bleeding. You can, see that later on as synechia, which may form. So it's a little more detailed of a procedure, but you know what? We're really not doing very many of these anymore. First off, you don't really see argon lasers anymore. Most of these lasers nowadays are solid state, which is nice because they're compact. They fit in your office. But I would say that, SLT has really become the procedure of choice in terms of managing open-angle glaucoma. SLT has become a primary care, or a primary therapy, okay? I don't think that's really a question anymore. When it first hit the scene several years back, the argument was, well, do you go straight to the laser, or do we go through the whole rigmarole of medical management with drops, before that? In this day and age, SLT is a primary therapy at NSU. We have a few glaucoma, fellowship-trained glaucoma surgeons in our area. I know one of them that pretty much exclusively performs SLT as a primary therapy on his glaucoma patients. So you're gonna see some ALT in the future, but probably not much. And if you're going to invest, in equipment and technology, I would certainly be looking at an SLT laser, not really a green laser or a photocoagulator for purposes of ALT. Now, there's other things you can do with green lasers, but I don't know that that's actually going to pay for the instrument in the future. All right, next patient. This patient now has a history of intermittent angle closure. Okay, she actually had glaucomflecken. You all know what glaucomflecken is. I've got a picture coming up here. That's a pretty telltale sign of what's going on. So on the examination, we noticed that her angles are pretty much non-existent or closed off. And on gonioscopy, that was verified. And nowadays, we have OCT, so we can see exactly what's going on. It's no longer really a question of do you have narrow angles or are you at risk for angle closure. We can see with very high detail what is happening. Okay, so her pressures were 19, which is fine, but still, if you see glaucom flecking, that, pretty much tells you that this patient has had angle closure attack in the past. That's what that looks like. You just see those little flakes, little specks of debris on the anterior capsule of the lens. So we're going to do a PI. Okay. Now, if this is in between attacks, we can call it a prophylactic PI if you want, or maybe your patient really hasn't even experienced an attack, but you don't want to let them get to that point. So we're going to use a YAG laser in this case. Now you can do a PI with either a YAG or a green laser, and again there are pros and cons, and times when one might be a little more efficient than the other, but I would say that I generally do them with a YAG laser. I think most of the students we teach and most of the residents at NSU prefer the YAG for various reasons. Obviously, you pick a thin spot. Again, the parameters are on the left there. We're not really going to go through all that. We do pre-treat, by the way, with pilocarpine to put the iris on stretch, and we look for a thin spot. So we look for a small crypt, either superiorly, which is the traditional place to put these. Although now, some of you may have seen PIs horizontally. Anyone here seen a PI at 9 or at 3? Yeah, there is I wouldn't say it's a revolution, but there is certainly a school of thought that if you put these PIs at 3 o'clock or at 9 o'clock, horizontally, you're going to avoid some optical phenomena, some aberrations that may be induced by putting the PI superiorly if it's put low enough to where the superior tear film or meniscus, where the lid and the tear film form a small meniscus. The thought is that it acts more or less as a prism, and it can actually cause some light scatter through the PI up there and cause some discomfort for the patient. I got to tell you that I've always put my PIs up there. Everybody that I know from my generation has always done a superior PI. I can't think of a patient that has come back after that saying that they have had an issue, but obviously it's occurred. And there are some well-respected people now that are promoting PIs at 3 or 9 o'clock, okay? So that may be something, to keep in mind. And again, as things evolve, we'll get some more feedback and some more information. And, maybe one day there will be good reason to go with one or the other. When I do my PIs, I'm comfortable. You tend to stick with what you know. So I'm comfortable up here. That's where mine go. Somebody else may argue differently. Either way, about 1 millimeter to 1.5 millimeters is how large you want to make them. As you saw in the video here, there was a little pigment. How do you know you're through? That's a question that the students are always asking. How do you know you're through? Is it when you can transilluminate through the pupil and it looks like it's wide open? Not really, because you might still have a little thin membrane there that is you're not going to be able to see, and it's going to look, if you just transilluminate and you're looking at the reflex coming back from the treatment area, it may look like it's wide open, and yet there's still a little membrane there that will argue otherwise. So the only way that you're sure that it is patent is when you are seeing that pigment from the posterior iris come forward, especially in a high pressure situation. It's just going to come right at you. Okay, you're going to take a shot. You're going to see some of that brown pigment, and it may look like a cloud of, they've called it tobacco dust, they've called it all sorts of things. You'll just see a burst of pigment come right at you, flowing in the direction of the aqueous currents that are now coming right at you. And that is your clue or the indicator that you have actually gone through, and that is now a patent PI. Now, if you're in a situation where you have an angle closure, you should immediately see the chamber deepen as well. Okay, so you're going to have a few clues, but don't go just by transillumination, because that's not 100%. Okay. All right, now we get to the next patient, and this is a 39-year-old with a history again of open-angle glaucoma, but he was just diagnosed about a month ago, and he's going to tell us that, I'm real squeamish about putting things in my eye or near my eye. So I don't get a sense, or I wouldn't have gotten a sense that this individual would have been very compliant with his drops. Again, we are now in a day and age when SLT is considered primary therapy. Okay, so we can talk to the patient about SLT, and in this case, this is what we chose. Now, I will tell you, SLT, if I was starting, if I was just learning how to do this, how to do lasers in general, I couldn't ask for a better procedure than an SLT, okay? SLT is probably the simplest laser that you can do. It's not only technically not very demanding. You know, what do you need to do to be able to do SLT? You need to be able to do a good gonioscopy, and that's really it, okay? If you can do gonioscopy, you can do SLT. Positioning is not really that much of an issue. Okay? In fact, you don't focus that laser spot. The spot won't focus. Let me put it that way. It's a very large spotlight, okay? And you just center it over the meshwork. And what you focus is the meshwork. Okay, so just get your structures in view, and then you just shine that spot. You know, wherever your starting spot is, you will position yourself, and then you take your shot, and then you just move over to where your big red spots there just touch each other, or maybe just intersect slightly, so that you get about 50 burns across 180 degrees. So you don't really have to focus the laser. You're not going to see much of a reaction, unlike the ALT where you're supposed to see a blanching. Here you may occasionally see a little bubble, and that's it, okay? And that's what's telling you that you've delivered the therapy. So you're going to make about 50 spots across 180. We actually do 360 nowadays, so we actually treat the whole eye. It'll take you about 2 minutes to do that, okay? It's a very comfortable procedure for the patient. Sometimes ALT is not so comfortable. This is generally very comfortable for the patient. The worst thing they complain about, in my experience, is that you put the goniosol on the lens or Celluvisc, whatever you're using. They don't like that, and they want you to wash that out. But that's generally it. Worst case scenario here, it's ineffective. So you don't really traumatize much because of the nature of SLT. Okay, and we can get into that at some other time, but I just want to say that if you're starting out in lasers, this is probably the best way to get into anterior segment lasers. Okay, and all our students know this. The first one you want to do is an SLT, because it's the lowest stress. Lowest stress for the student learning, lowest stress for the patient. They're generally very comfortable throughout the procedure. So if you're going to start out doing lasers, here's how we would like to start, with SLT as your first case. All right, so those are generally the laser procedures that we see routinely at NSU. And I would say SLT is probably the most common nowadays, okay? So I probably would rate them in order of frequency. SLT, posterior capsulotomy. Sometimes we'll do an anterior capsulotomy along with that. And then the PI, is we do prophylactic PIs, and we have all the imaging technology now. So the OCT suggests that this patient might benefit from a prophylactic PI. We'll go ahead and do that. Occasionally, you might still see an ALT, but I think that ALT is really on the way out. I don't know anyone in my area that's doing very many of them. All right, non-laser procedures now. So now we have a patient who is concerned about a lesion adjacent to her lateral brow, okay, lateral canthal area. It's been there for about 3 years. Appears to be growing, evolving. So we do, A, B, C, D, E. You all know, that mnemonic. Asymmetry, borders, color, diameter, E for evolution. Anytime something's changing, that's really all you need to know to warrant a biopsy, okay? If things are evolving, if things are changing, it's not really a cosmetic issue anymore. Something is happening, especially, at this one was lateral to the canthus there. That's an area where, you don't have a lot of tissue to deal with. So if something is growing, you want to find out what it is before it gets too large, and then the reconstruction becomes a lot more complicated and costly. She's also reporting a history of bleeding. Okay, so that's a red flag as well. Okay, and look at this. She admits to visiting tanning salons when she was in her 20s and 30s. So she's got several risk factors here. So we're going to do a biopsy, and this is a little clip of a punch biopsy, in fact. And I've sort of been on on a crusade to get optometrists in Oklahoma to do more biopsies, because we remove things. You know what, if you remove something, it's not much more effort to put it in the little cup and call the lab. They'll come pick it up, and pathologist will tell you exactly what it is. Okay. In fact, at that point, the lab takes over. They bill the patient directly. You're out of it at that point, except for the fact that you're going to get a little piece of paper, a little report back. It's going to tell you exactly what it is. It's important because we manage benign things a little bit differently than we will manage malignancies. Again, if we don't have a lot of room to work with, if that lesion comes back and it's benign, I may just come back and use a radiofrequency handpiece to ablate it, just treat the lesion directly and not even touch any of the surrounding normal tissue. If that comes back and that's malignant, well, now we have to do a wider margin excision with clear tissue all the way around to make sure that we've got it all. So the way you manage it is a little different. So doing a biopsy, even an incisional biopsy, where you don't take the whole lesion at once, but just take a little sample and figure out what it is before you decide what the appropriate definitive therapy is, it can be very, very beneficial. Now, this is pretty straightforward. That was a little anesthetic injection that you saw, because we do want to make this a comfortable process, comfortable procedure for the patient. So we're going to anesthetize. We generally then will prep the skin with a little betadine, which is what you see here. That's 10% betadine. That's the standard skin prep, okay, 10% betadine. There is also a 5% ophthalmic betadine, which you can use for something like this. That would be fine. 5% betadine is a non-detergent-based solution. If you get it in the eye, it's not going to burn. It's not going to sting as bad as the regular stuff that you can get over the counter, which is 10% betadine. So anyway, you prep the skin. If they're allergic to betadine, by the way, we can use chlorhexidine, or even for something this small, alcohol. Okay, you just clean the skin with alcohol. Check, make sure that they're numb before you do anything. Now we're going to use what's called a biopsy punch, which is a little cookie cutter, okay? And they come in various sizes, so you pick one that's appropriate for the lesion that you're working on. I would say that we generally use about 2 or 3 millimeter punches, and these are very, they're fairly cheap, fairly inexpensive. You can stock, a variety of sizes. They're disposable, one-time use. Now, around the eye or on the eyelid, you don't do this the same way you do it elsewhere. Elsewhere on thicker skin, you actually bury that because you want to get a sample, a core sample, all the way down to the subcutaneous fat. We don't really do that around the eye. All you want to do is just break the skin, okay? We're just breaking the epidermis. It does bleed, and that's normal, okay? Students sometimes are not prepared for that. But anyway, you just want to break the skin, then take a little needle or a forceps like that, pull up the little plug, and go snip, and that's it, okay? That goes in the specimen cup, okay, which the lab will provide you free of charge. These are Westcott scissors, by the way. That's what I use for this, okay? Small iris or small Westcott scissors. That goes in the formalin cup, okay? Then, your office will call the lab. They send a courier out to pick that up. And in 2 or 3 days, or sometimes even less, nowadays, a lot of these labs are set up to do this online, you will have the path report, okay? And then you can make treatment decisions with a little more confidence, okay? Because we're no longer guessing. Now, you don't do anything to that. You don't stitch that. Don't cauterize it. Just put a little pressure on it till it stops bleeding. If it's bleeding, a little ointment and a Band-Aid until we know what that is, okay? You will actually use a biopsy code. You get paid a little more for doing this, okay? So if you just remove a papilloma or a skin tag, don't biopsy it, you get paid X amount. If you submit it, okay, for biopsy, you get paid a little more because now you're going to get a path report back. You're going to have to go through that and make some sort of professional decision, okay? If you use a biopsy code, by the way, be sure that path report now becomes part of your medical record, okay? Because if you ever get audited, that's how you're going to prove that you actually did send it in and get a report back and act on it and not just charge the higher paying biopsy code, okay? Yes, ma'am. That's a good question. On something like that, it probably doesn't matter. If you have the opportunity to get the margin to include some normal tissue, Sometimes that does help the pathologist make the diagnosis because they can see that transition zone. If you're dealing with a bullous or a blistering lesion, if you're dealing with a lesion that overlaps onto a mucous membrane, it's important to get that transition zone so that they can see lesion and then what you think is normal tissue, okay? So with blistering type lesions, yes, that's needed. With something like that, probably not. So, if it was positioned, in a spot where it may cause problems if you remove some normal tissue, like close to the lid margin or the canthus, where again, you don't have a lot of normal tissue to deal with, then no, you could go through the center, okay, and that would be fine. But with the blistering type lesions or lesions that involve a mucous membrane, you do want to get that transition zone, so you would try to get it at the periphery. Yeah, nice observation. Okay, next patient. This patient is a 79-year-old male with chronic epiphora. Okay, no real history of trauma. Really, the exam is fairly unremarkable, but it's just been getting worse. And some people don't consider this a surgery, but I've seen enough residents now do this, and they tend to be very timid. So let me just show you the way I do this. And I was timid once upon a time. I remember when I finished optometry school, and I like to tell the story, we weren't even doing punctal plugs yet. And I remember my first year in medical school, I went back to ODCE, and they were talking about punctal plugs. And I remember looking up there going, oh, I could never do that. That's just too invasive. Here's what you want to do. Obviously, I use 4% lidocaine on a Wexel sponge to numb them up. Okay, and after about a minute, they're nice and numb. Use a dilator and be fairly aggressive. You want to open that up, okay? So get in there. You may even use a dilator of 2 different sizes. If you can't get in with a large one initially, use a smaller gauge to get that opening to where then you can come back with a little higher gauge or smaller gauge, broader based dilator to open that up. Now the trick to this is when you put the irrigation cannula in. And by the way, I use a long lacrimal irrigation cannula. I don't use these short ones that for some reason come in these kits that our optometry students buy. It's a long polished cannula that actually you will advance all the way until you hit the nasal bone. So you will go all through the canaliculus into the nasolacrimal sac. And when you irrigate, you need to use a little force. Okay, there you see that little mucus plug that came out. Okay, you probably wouldn't get that if you were using that short cannula and you were just more or less in the horizontal portion of the canaliculus. And another trick is I like to take a Q-tip like you saw here and stretch that whole system out horizontally. That straightens out the whole canaliculus so that the cannula goes in very easily, and you advance it until you hit the bone, and then you plunge. You press down on the plunger, and if you have a plug like that, it will either go down the back of the throat or you'll see it come out the other punctum. If you don't get anything, the patient should tell you that I am tasting something down the back of my throat. If you don't get that or you don't see anything, then in an adult you probably have either a totally occluded nasolacrimal duct or there's some other pathology there that needs to be further investigated. I use this. I don't do the Jones testing and all that. I don't do any of this. Now I do put some fluorescein in the saline that I irrigate. Okay, and this can be both therapeutic and diagnostic. Okay, if they can taste a little saline, a little salt down the back of their throat, that tells you that at least you at least have a partial occlusion, okay, but that it is open to some degree. And what that tells us, or what that tells me, is I might, instead of doing a surgery, a DCR, dacryocysto-rhinostomy, which is a surgery you don't want to have done on yourself, you don't have to. If it's partially occluded, I can run a little catheter with a balloon and dilate the whole system. I can do that in the office, okay? And that is a much better deal than a surgery, all right? If it's totally occluded, then really a DCR is indicated because there's no way that you're going to get the little catheter in there. So this procedure, to me is both diagnostic and therapeutic. If you can get some saline through, it's at least partially open, okay? And if they continue to have problems, you irrigate them out well, bring them back, in a couple of weeks. If they continue to have problems, you can try the balloon dactyoplasty. If not, again, you may have cured the problem, okay, with the irrigation, if it was, for example, a plug like you saw there, okay? Yes?
What setting are you doing these procedures in? Do you do it behind a slit lamp, or are you doing it in the surgical suite?
I'm used to just having people laying down. If I need magnification, I will put on some loupes, or we have an operating scope. And you don't need a very expensive operating scope. You just need to be able to see. Okay? I generally don't do these things with folks sitting behind the slit lamp because they're a little unstable. Okay? And for some of these things, you do need them to be very comfortable and very still. Okay, here we have a small papilloma. Now we have anesthetized this. The trick here, okay, and we see these all the time, and our students get lots of practice here. They are bothersome, and people, want them treated. Okay, so the trick here is that you shave that, you cut that, use a scalpel, a scissor, a radio frequency device. Whatever you're going to use to cut the tissue, you're going to, number one, not tent up. You can use the tweezer or the forceps, as you saw there, to support, but you don't want to tent up on the lesion while you amputate it at the base, because when you tent up, you're also pulling up some of the subcutaneous tissue, and you will wind up with a much deeper, much broader hole, crater, than you intended to. So you just support, and you just want to trim that flush with the surrounding skin, okay? All of these benign lesions like this, they butt off the surface. They don't grow down into the dermis. They cannot breach the basal lamina of the epidermis. That's why they're benign. So most of these things that we deal with basically butt off, and if you just debride the surface epithelium, you're done with it. So in this case, what we did was used a little scissor. Okay, we amputated most of the lesion, and then we came back with that little device that you saw there was a radio frequency electrode, and what it does is ablates tissue. So it basically just vaporizes tissue. It also cauterizes or provides a little hemostasis. So as you saw there, we remove the lesion, you come back and you treat the base till it looks pretty, and you're done. Okay, they go home and they'll use a little antibiotic for a week, and that's it. All right, we'll get through this one. I think we're out of time here. This individual, I remember this guy, had about 50 or 60 of these seborrheic keratoses on the face, up and down the neck, on the shoulder, on both sides. A dermatologist had probably removed 10 or 20 of these things by freezing them, and they had biopsied some, but the dermatologist didn't want to touch the eyelid, okay? So he had these on the eyelid that were bothering him, and this is how we treated it. And if you haven't seen a radio frequency device, prepare to be amazed. And this is actually probably a good one to finish with, because you'll go home going, wow, I didn't know you could do that. Anesthesia, just an intradermal injection. Now you see that little bit of bleeding? Okay, major complication, right? You take a Q-tip and you hold a little pressure. That's all you do. And we have about an hour lecture I can do at some point in the future on how to do these injections around the eye. It's not very difficult. Betadine again. Now, for one or two little lesions like that, do you really need to go through the whole rigmarole of betadine and draping? Probably not. If you're just doing one or two lesions, you can clean with betadine, but an alcohol wipe would probably suffice. Anytime that you anticipate, or if you don't know, if you think you might have to use a suture, then you do have to create a sterile field, because your suture has to be, you don't lay your suture down other than on a sterile field. So you would go through all this process and then put a drape on. This is just a fenestrated eye drape. That little cardboard thing you see there on the right is it's called a Nevius drape retractor, and it just keeps the drape off the patient's nose and mouth so that they don't feel like they're smothered. Again, we will test for anesthesia, and if the patient is comfortable, this now is a radio frequency device that uses a wire as the active electrode. It doesn't get hot. What that wire does is it sends a radio wave of about 4 megahertz into the tissue, The tissue absorbs the radio energy. The water in the cytoplasm of the cell heats up to the point where the cell membranes lyse, and that's the little bit of smoke that you see coming off of this is basically that steam that's carrying away particulate matter. And that's how it cuts, okay? So basically, we can use that to debride the tissue just like we were wiping the epithelium off the cornea, okay? That little bit of tissue you saw, by the way, you could pick that up, put it in a cup, and submit that for a biopsy. And depending on what configuration of wire you use, you can do all sorts of things with this, okay? So this is just one example of what we can do with radiosurgery. We use these instruments to close off puncta, to ablate follicles in the case of trichiasis. Anything you can do with a scalpel, you can do with some configuration of wire electrode. The difference, as you see here, is you're also sealing off the little capillaries and lymphatics as you cut or treat. So there's little to no bleeding, little to no swelling. There's no downtime on this, okay? Once upon a time, I would have had to take a scalpel, cut around those lesions, make a little ellipse, dissect it off of the face, and then put stitches in to close those wounds. Here, all we've done is we've basically wiped them away, and the patient goes right back to work. Now, is there anybody here that doesn't think they can touch the bump with the wire? Because that's the skill, that you have to be able to do this. This does not take years and years of medical school. I didn't learn this in medical school. Did medical school prepare me to do this? No. Did medical school prepare me to do any of these lasers I showed you? No. You know what prepared me to do the lasers? Video games. Okay? All right, okay, we're out of time. I will happily leave this. There's a couple of more videos that you can see here. One on, this is punctal closure, which is very straightforward. Trichiasis, you can watch that. I will leave this, and you can make this video available, or this available. There is so much that we just do not have time to cover, but I can tell you it's been a real pleasure for me over these past 20 years to see how optometry in our neck of the woods has grown and expanded to include all sorts of things that we can help our patients with now, and it's very gratifying. So I know a lot of docs in our area that have really incorporated so many of these things into their practices. Their practices are now so diverse. And they've truly become, primary care practitioners. I've got a plane to catch. I'll hang out here for maybe 5-10 minutes, and I want to thank you all for inviting me this morning. Nice to meet all my cousins from California, and if you're ever in Oklahoma, please come by and visit. We can introduce you to Oklahoma barbecue. Okay.